Post-dural puncture headache or PDPH is a potential complication of lumbar puncture. PDPH may occur after intentional dural puncture with spinal needle or unintentional dural puncture with epidural needle. The rate of PDPH after dural puncture with spinal needle ranged between 1.5% to 11.2%. And after a dural puncture with an epidural needle, the risk of PDPH is 52.1%. The symptoms associated with post-dural puncture headache are nausea about 60%, vomiting 24%, neck stiffness 43%, ocular symptoms 13%, and auditory symptoms 12%. Ocular symptoms include photophobia, diplopia, and difficulty in accommodation. Auditory symptoms include hearing loss and tinnitus. Hearing loss is usually low frequency range and may be secondary to endolymph and perilymph imbalance and alteration of the hair cell position in inner ear. Other symptoms associated with PDPH includes seizure, vertigo, bilateral forearm pain, abdominal pain, and diarrhea. Cranial nerve palsy, thought to be secondary to nerve traction caused by low CSF volume, is associated with the PDPH. The sixth cranial nerve is most susceptible to traction during the long and the tortuous intracranial course. The traction results in failure of the involved eye to abduct, and patient may have diplopia or extraocular muscle paralysis. Headaches caused by dural puncture with a spinal needle ranged in duration from 1 to 7 days. By ICH-D3 beta criteria, headache must appear within 5 days of the dural puncture. It is seen that 65% of patients developed symptoms within 24 hours of lumbar puncture and the 92% patient developed symptoms within 48 hours. Imaging investigation are not routinely recommended for the postpartum patient with PDPH unless the symptoms suggest other diagnosis or the diagnosis of the PDPH is in doubt. Contrast enhanced MRI is the method of choice. The findings include marked diffused pachymeningeal thickening and enhancement, compression of the ventricles, caudal displacement of the brainstem and the optic chiasma, cerebellar ectopia, pituitary enlargement and enhancement, expansion of the suprasagittal sinus. Debate continues regarding the precise etiology of the PDPH symptoms. The original theory was pain-sensitive nerve fibers were stimulated by downward shift of brain secondary to the loss of the CSF volume. The total CSF volume is approximately 150 ml. The production rate is approximately 0.35 ml per minute, or daily rate of production is 500 ml. The rate of CSF leakage through a dural hole may exceed the rate of the CSF production. If this occurs, low CSF pressure results in a loss of Cushing effect provided by intracranial fluids. CSF pressure during labor is normal between contraction, but increases significantly during painful contraction. Effective epidural analgesia attenuates this increase in the CSF pressure. Not all patients with PDPH symptoms have decreased CSF pressure, and not all patients with a significant CSF leak experience symptoms. The pain of the PDPH may be caused in a part by increase in the cerebral blood flow and cerebral vasodilation as a consequence of low CSF pressure or volume. The occurrence of cerebral vasodilation may explain the relief of the headache symptoms with treatment with vasoconstrictors such as the caffeine, theophylline, and sumatriptan. PDPH is uncommon in patients older than 60 years of age and is most common in patients younger than 40 years of age. In elderly, the dura may be inelastic and less likely to gap after puncture. CSF leak may be impeded by adhesions and calcification. Females are more prone for PDPH than the males. This difference may be related to the difference in the cerebrovascular reactivity. It is well known that migraine headaches occur predominantly in females and are influenced by hormonal changes. The patient with unintentional dural puncture during epidural catheter placement, the rate of PDPH is lower in women who delivered via cesarean in compared with those that delivered vaginally. This is due to the expulsion effort at the second stage of labor that causes increase in the CSF leak. The relationship between the body mass index and the risk of the PDPH after dural puncture is inconsistent. PDPH is less commonly seen with the obese patient. The possible mechanisms are: obese patient has increased abdominal pressure, which may reduce the extent of CSF leak, and reduced physical activity in comparison to the active one. A history of the PDPH after previous spinal anesthesia is associated with the development of the PDPH with subsequent spinal anesthesia. This finding suggests that certain individuals are predisposed to the development of the PDPH. Multiple dural puncture significantly increases the risk of PDPH. Fluid leak through the dural puncture site is slower with pencil point needle compared with a beveled needle. Pencil point spinal needle tip reduces the incidence of the PDPH. The incidence is lower with sprott needle than with the Quincke needle of smaller gauge. With the Quincke needle, the incidence and severity of the PDPH are directly related to the size of the needle. The incidence of the PDPH is lower with 27 gauge needle than with the 25 and 26 gauge needles. It was thought that the dural fibers run in longitudinal direction, and therefore inserting the needle parallel to the long axis of the spine causes less trauma to the dura. However, electron microscope has revealed that dura consists of multidirectional interlacing collagen fibers with both transverse and longitudinal elastic fibers. Puncturing the dura with Quincke needle bevel parallel to the long axis of the spine reduces the incidence of the PDPH by 70% compared with the perpendicular orientation. This is due to the result of less tension on the dural hole and therefore a smaller aperture with less CSF leak when the needle is inserted parallel to the long axis of the spine. There is no difference found in fluid leak among the various sizes of the epidural needle. The incidence of the PDPH is greater when unintentional dural puncture occur with 16 gauge compared with an 18 gauge epidural needle. It may be beneficial to insert the needle via paramedian approach to reduce the incidence of PDPH, as there is formation of dural flap when we insert the needle via paramedian approach. There is conflicting evidence as to whether the spinal needle approach affects the incidence of PDPH. Currently, data are insufficient to recommend either the median or paramedian approach for reduction of PDPH. Many practices and maneuvers have been used in an attempt to reduce the incidence of PDPH after unintentional dural puncture, most with limited success. Bed rest. While lying down decreases the severity of the PDPH, immobility should not be used as a maneuver to prevent the PDPH, as pregnant women are hypercoagulable and increases the risk of deep vein thrombosis and pulmonary embolism. Despite the widespread practice of encouraging women to increase oral fluid intake, there is little evidence that greater hydration prevents PDPH. Oral or intravenous caffeine have been used to prevent PDPH, but this does not reduce the incidence of the headache. Prophylactic caffeine is not advocated for prevention of PDPH. Cosintropin is an ACTH analog, is effective in reducing the incidence of the PDPH. The mechanism is unknown but may be related to aldosterone stimulating effect on volume expansion, modulation of the pain perception via central endorphin-like action, and increased CSF production by enhanced sodium ion transport. Prophylactic neuroaxial administration of hydrophilic or lipophilic opioid does not reduce the incidence of the PDPH after spinal anesthesia or unintentional dural puncture. The movement of the morphine across the dura is increased by the presence of large gauge needle puncture, possibly increases the risk of the respiratory depression. That should be kept in mind. Intrathecal catheter might reduces the immediate CSF leak into the epidural space by mechanical obstruction, as well as inducing an inflammatory fibrous reaction in the dura rent, thus facilitate closure of the puncture after removal of the catheter. Current evidence suggests that advancing a traditional epidural catheter into the intrathecal space after unintentional dural puncture does not appear to reduce the incidence of the PDPH, but may reduces its severity or the need for the epidural blood patch. Sometimes prophylactic epidural or intrathecal saline may be used. Prophylactic blood patch or prophylactic dextran patch can also be used. If performed, then these procedures should be delayed until there is resolution of the residual neuroblockade. The occurrence of the pain during injection is signal for the anesthesia provider to stop injection of blood. Dextran injection can be performed before regression of the local anesthetic effect. Early treatment of PDPH is indicated. Not only does this avoid the vicious cycle of immobility, weakness and depression, but also may help to prevent the rare case of subdural hematoma, chronic headache or cranial nerve palsy in the patient with persistent PDPH. Psychological support. Patient is aware that PDPH is an iatrogenic problem. Thus, patient may be angry, depressed and tearful. It is important to disclose the risk for the PDPH at the pre-operative interview. While having headache, it is very difficult to take care of the newborn as well as to interact with the other family members. Severe PDPH may delay the discharge from the hospital and have economic consequences. It is essential that anesthesia provider visit patient at least once daily to explain symptoms and prognosis, give support and offer therapeutic options. Nurses can help patient by ensuring the adequate analgesia given on a regular interval and by teaching alternative breastfeeding technique such as lateral horizontal position. The anesthesia provider must write detailed note of the patient's record. The prone position relieve PDPH in some patients because increased intra-abdominal pressure result in increase in the CSF pressure. Significant relief should occur when patient assumes the horizontal position. However, there is no evidence that remaining supine for prolonged period treats or shortens the duration of headache. Enhanced oral hydration remains a popular therapy initiated by the most of anesthesiologists. But there is no evidence that vigorous hydration has any therapeutic benefit in patients with normal fluid intake. The safe and effective drug therapy for PDPH would be very useful even if relieve it transiently. The current gold standard therapy, an epidural blood patch, is not appropriate or effective in all patients. The drugs used are caffeine, gabapentin, hydrocortisone, theophylline, sumatriptan, adrenocorticotropic hormone, pregabalin, and cosintropin. Caffeine and theophylline seemed more beneficial for the treatment of PDPH. The evidence was inconclusive for the sumatriptan, adrenocorticotropic hormone, pregabalin, and cosintropin. Caffeine has been used to treat PDPH for many years. Caffeine is a cerebral vasoconstrictor. Caffeine also increases CSF production by stimulating sodium-potassium pump. Caffeine appears in breast milk in very small amount. It seems wise to restrict the prescription of oral caffeine to 600 mg in 24 hours. Long-term caffeine therapy cannot be recommended. Theophylline is a methylxanthine has been used for the management of the PDPH. Theophylline is not commonly used because it has narrow safety profile. Sumatriptan is a serotonin receptor agonist with cerebral vasoconstrictor properties that is administered subcutaneously for the treatment of migraine headache. Side effect includes pain at the injection site and uncommonly chest tightness and coronary artery vasospasm. Dose is 6 mg subcutaneously. Mood elevation, anti-inflammatory effects, increased endorphin level and augmented intravascular volume are possible mechanism of action in relief of headache following ACTH administration. Additional study is needed to assess the safety and the efficacy of the cosintropin for the prevention and the treatment of the PDPH. With current evidence, ACTH therapy is not recommended as the first-line treatment of the PDPH. Other drugs include pregabalin, methyl argonovin, hydrocortisone and gabapentin. All 4 drugs require further study before they can be recommended for the treatment of the PDPH. Patient with PDPH may be treated with the epidural morphine 3.5 to 4.5 mg. However, this therapy should be used with caution because epidural morphine injected into the presence of a large dural puncture site may pass readily into the CSF and predispose to respiratory depression. Additionally, these patients may require hospitalization for 24 hours to assess the respiratory depression. The use of epidural or the intrathecal fluid to treat the PDPH precedes the use of epidural blood patch. This may be due to the increase in the CSF pressure after fluid injection. Prolonged epidural saline infusion may provide better therapy for PDPH symptoms than therapy with a single bolus. Epidural blood patch therapy is the most reliable method for relieving the PDPH symptoms. Injection of the blood increases the lumbar CSF pressure, an action that restores intracranial CSF pressure and decreases symptoms. Indicated for the treatment of post-dural puncture headache who do not respond to conservative treatment and the person who will not tolerate the pain for 7 to 10 days. The most of the practitioner will use approximately 20 ml injected slowly 30 to 60 seconds to create a blood patch. Immediate problems associated with post-dural puncture headache include the inability to perform activities of daily living such as providing care for the newborn, an extended duration of hospitalization, and a higher number of emergency department visits. Rare but serious complications may occur following dural puncture and PDPH include subdural hematoma, cerebral venous sinus thrombosis, chronic headache, diplopia, and hearing loss. The subdural hematoma is associated with new neurological symptoms in addition to changing headache characteristics. Ongoing intracranial hypotension lead to caudal movement of brain and the rupture of the fragile bridging subdural veins. This causes subdural hematoma. Cerebral venous and sinus thrombosis may occur due to the cerebral venous dilation and the hypercoagulability of pregnancy. Anticoagulation therapy is recommended for the patient with cerebral venous and sinus thrombosis. Diplopia or hearing loss after dural puncture secondary to cranial nerve dysfunction may be permanent even after successful treatment of PDPH with an epidural blood patch. Some patients may have persistence of headache, backache, or cranial nerve symptoms.